Okay, I'm Stephen Rulisa. I'm obstetrician gynecologist and I'm the head of OBGYN department at the University of Rwanda School of Medicine.
I'm Washington Hill. I'm a maternal fetal medicine specialist. I'm with the HRH program for Rwanda through Duke University, and I'm at the teaching hospital in Kigali.
Well, so the hospital is the biggest hospital in Rwanda and is a teaching referral hospital. So we have over 40 district hospitals and they all refer to the district, to our referral hospital. So it's one of the biggest teaching hospitals. We have close to 8,000 deliveries here, and most of the patients are actually referred cases, so we don't have like normal deliveries is rare, so we have most of them are complicated cases from district hospital.
You see all kinds of complications for high-risk pregnancy, from ectopic pregnancies very early in the pregnancy, molar pregnancies, ruptured ectopic pregnancies, pre-eclampsia, eclampsia, postpartum hemorrhage, auto accidents,
uterine ruptures,
obstructed labor, all the complications that you could imagine. We see them all. These are patients, as Dr. Rulisa said, that are referred from any of a number of district hospitals to our facility. I think that we've been thinking about that for some time. We knew we were coming here. And the case that we'd like to discuss is actually one that we think the death could have been prevented. It was a patient who presented to the health center. Now, the system in Rwanda is the lowest level of care is the local health center. The health centers then feed into a district hospital. The district hospital then feeds into the tertiary or referral hospital. This was a patient approximately 24 years old. I think this was her second baby. She was being seen at a local health center and went in initially. She went in twice. She went in initially just complaining of a mild headache and a blood pressure that was a little normal, and her stomach was just feeling upset. She was seen by the healthcare team there, was given some medicine for her upset stomach, and sent home. She returned the next day. Her blood pressure was still normal. The pain in the right upper quadrant was still there, but she developed a little cough and felt a little problem breathing. She was evaluated. Her blood pressure was normal. She had no protein in her urine, and she was sent home. She was asked to come back in 2 days for her regular OB appointment. She came back in 2 days for her regular OB appointment. At that time, her blood pressure was 160 over 110, if I recall. She had 1+ or so protein in her urine. The pain had gotten worse, and now she had a severe headache and was seeing some spots before her eyes. She was kept at the district hospital and evaluated for a number of hours, probably around 6 hours, and then finally transferred to our hospital when she was having severe right upper quadrant pain. She was about 26 weeks pregnant. The baby was dead. You could see on ultrasound also not only that the baby was not moving, but that she had a hematoma of her liver.
The subcapsular hematoma of the liver.
And it was clear it was there. It was not ruptured, but there was a large collection of blood in the right upper quadrant. She was seen in consultation by surgery, who felt that she was stable. She needed to get some blood. She needed to get some platelets. And the plan was to reevaluate her the following morning. I saw her just before I went home that evening. She was not having a lot of pain. She was receiving blood. During the night, around 2 o'clock, she suddenly had a hypotensive episode. Probably that's when her liver capsule ruptured. She could not be resuscitated and she died.
So when you actually asked why they sent her home several times, she complained of right upper quadrant pain. But the healthcare workers never dug deep to know exactly what type of pain. They misinterpreted this pain into epigastric pain, which may be caused by irritation of the stomach or peptic cancer, and they gave some medication which they thought the pain was just maybe irritation of the stomach and peptic cancer. So they missed that, and one of the things why they missed right upper quadrant pain is that they measured the blood pressure and it was normal. So the biggest mistake that people can miss pre-eclampsia or even to eclampsia is that they think everyone must have high blood pressure, which is not the case. You can have preeclampsia with normal blood pressure. And so when they had the pain, they never asked exactly the quality of pain, the location of pain, they just had pain, okay, think probably it's the stomach. And if you have normal blood pressure, they tend to think that you cannot have preeclampsia with normal blood pressure.
And she actually had mild symptoms.
Yeah.
So both times that she was seen and sent home, she had mild headache. Pregnant women get a headache.
Yeah.
They all have a headache. So she had mild headache. She had some mild discomfort. It was diagnosed as something that perhaps she ate. Her blood pressure was normal, if at most just slightly elevated, and she had no protein in her urine. These are symptoms that are early symptoms of preeclampsia. That's the important message. The patient does not have to have real high blood pressure, protein in her urine, edema, headaches, and spots before her eyes. Anyone can diagnose that problem. The problem that we see are these patients with just very mild and early symptoms who are sent home. And remember, she came in one day, day one, and then she was finally seen at our hospital late day 4 or 5. Well, she had time to really develop very severe preeclampsia, and from which she died.
Usually what we need to tell these nurses is that whenever you're faced with a pregnant woman, you have to exclude the severe disease first.
Right.
So if someone coughs, you don't think of flu symptom, you think of exclude pulmonary edema. If someone has pain, you exclude subcapsular hematoma. You must think of HELP syndrome, which organs are most affected. Like the brain, if there's a headache, you don't take it as normal headache. If there's chest pain or cough, you think of pulmonary edema. If there's pain, you think of liver, and so on and so on. So you have to exclude severe symptoms or severe disease first.
Her mild symptoms were not picked up as being a cascade of symptoms of severe preeclampsia.
Yeah.
Even when she came back the second time and said, well, I'm just having a little mild shortness of breath. Just can't catch my wind. Well, in reality, even if her lungs are clear, she's starting to develop pulmonary edema.
So one thing is that if this woman comes back, you should not take her as an isolated case that came now. It should be a progress of why did she come yesterday? Because when you follow these symptoms, it's a cascade of symptoms that keeps coming. Like you have right upper quadrant pain, tomorrow is a headache, tomorrow is breathing symptoms. You should not isolate that today she came with chest pain, tomorrow she came with headache, the other day she came with that. You should not take them as isolated cases. You should take them as a cascade of signs and symptoms that add up to a severe disease somewhere.
And think of the worst.
Yes.
When a patient comes in who's pregnant and shortness of breath, and along with her other symptoms, her blood pressure, her pain, you don't think that, well, maybe she has a flu. Or maybe she just has a bad cough, or maybe she has a cold or upper respiratory infection. The resident, the healthcare team, what we're trying to emphasize is that the healthcare team has to think, well, what could this be in a woman who's 26 weeks pregnant? Could it be preeclampsia? Maybe her blood pressure is a little normal now, and I always tell residents, there's nothing wrong with admitting the patient and watching her overnight. And in the morning, if symptoms are gone and better and improved, and you've gotten lab work done, then you can send her home. But in the morning, if things are worse, then you have her there and you can diagnose her early. Well, remember this patient died. So let's say that we diagnose severe preeclampsia, which she had. Yes. Severe preeclampsia at 26 weeks. Then the recommendation is that she have labor-induced. So she would have lost the pregnancy. She ended up losing the pregnancy anyway. She would have lost the pregnancy, but she would have been alive.
But the other thing is that if they had detected the preeclampsia earlier, they should have started treatment. Magnesium sulfate is one of the recommended drugs. It should have started magnesium sulfate as early as possible. So that even if it progresses to severe and you go to termination of pregnancy, then you save the mother.
When you look at patients who die from preeclampsia, there frequently is first a delay in the diagnosis.
Yes.
That's the first thing. Then there's a delay in the transfer of the patient from the healthcare center to the district hospital. Check, this happened to this patient. There then is a delay of transport of from the district hospital to the tertiary care center. She was there 6 hours. That's another point. And then there's a delay, as Dr. Rulisa said, initiation of therapy.
Yes, that's a taking decision.
Now,
for example, if you have this dilemma between when a patient is pregnant, the decision to treatment. And remember, one of the treatments is termination of pregnancy. And someone may argue that I probably treat and I can push the pregnancy to a certain viability and then the baby can survive. So you also need to take this decision as early as possible to save the mother. So also delay to take a decision is a very important factor that people should say.
All those delays result in maternal death.
The main point is that you should always exclude the severest disease in a pregnant patient. So if anyone presents to you when he's pregnant, exclude the main killer of the patient. Now with the main killer of pregnant mothers, we're talking about what Washington said about like preeclampsia is one of them. Postpartum hemorrhage is another example. So in this case, they should have excluded preeclampsia immediately. Now if she has a flu, that's fine, you can manage it, but you should exclude the most killer fast.
And then she comes back a second time, you have a second chance to make this diagnosis early. Another important point is the patients die or have severe morbidity because of delays. One delay that we didn't talk about is a delay in the patient coming in to begin with. We see patients who come in and we ask the patient's mother, sometimes if a patient comes in and she's in a coma, well, did anything happen yesterday? And she says, oh yes, she had a fit yesterday and she woke up and we kept her home. So there's a delay in bringing the patient in to begin with.
So maybe that one I can pick from there is that that's a component of educating our patients. So whenever patients come to you, when they are normal, you should tell them the alarming signs of the most killer diseases. That if you have headache, do not take it as simple headache. See a healthcare worker. If you have pain somewhere, I mean, you may not know the right quadrant thing. You tell them, if you have pain here, go. Signs of high blood pressure, if you have blurred vision, if you have headache, if you feel general weakness, go to see a patient. Do not think, yeah, this is normal problems. Normal headache, yeah, everyone gets headache, even males get headache, even non-pregnant women get headache. or you see lower limb edema, you should explain to them when they are normal, that whenever they see these alarming signs, they should go to see the healthcare worker.
And not wait for your appointment. I've had patients who say, well, it's Saturday, and they're having symptoms. They don't feel right. Well, I have an appointment on Monday, so I'll just wait till Monday.
Yeah.
Monday they may be worse, or Monday they may be dead.
And that's what usually happens. You ask them, why did you come early? Well, it wasn't very severe. I thought they would come. You gave me an appointment on 14, so I thought I should come on 14. She didn't know that this would come to a cascade of signs and symptoms until she's like starts convulsing. Well, what I can say is that the healthcare workers should always be aware of these killer diseases, and they should always try to detect them as early as possible. And they should, as Dr. Hill says, always try to know the danger signs of the killer diseases and try to avoid these delays. You can only avoid the delay on the patient side when you educate them when they are normal. You don't educate them when they already have a problem. So you should educate them earlier so that you avoid the delay by the patient. And then the healthcare workers should avoid the delays to transfer, to take decisions, and so on and so forth.
Thank you very much.
Thank you.